This last session is a very focused topic. It's on using routinely collected data in research. And the article that we're going to discuss today is just an example of the type of question that you could answer, or is an example of a question that was answered using existing data. So our goals are to discuss the strengths and limitations of your routinely collected data, to discuss the article that NDR TB treatment outcomes in Lesotho, and then to start thinking about what questions you could answer using the data that exists within Partners in Health and with the Ministry of Health. So I just want to say there is data everywhere. I mean, we're literally just surrounded by data, and this is just one example of the Community Health Worker Program. So I've done quite a bit of work with our team here looking at the data collected from the Community Health Worker Program, and you can see from that program they collect data on individual children, and so that data sits with the community health worker in what we call sick child encounter forms. That data is then summarized into registers. So the same information, some of it is transferred into registers, and every month that data is aggregated into monthly reports at the village level. It's then aggregated into cell level reports, so multiple villages will come together and report what's happening in their village every month. It then goes up to the health center level, and then here it's entered into an electronic database. And so there's multiple levels of data. If I wanted to do something simple and quick, I could look to the electronic database. It's already in an easy to analyze form. If I want individual level data, I could go back to these forms to find out more information about the children. And so there is a ton of data just within one program, Community Health. And this isn't even all the community health data. This is just the community health data related to children who are sick. There's also community health data related to pregnant women. There's community health data related to household characteristics. There is so much data just within the community health program that we're not using. So this is just an idea of the types of information they're collecting. They're collecting information on sick child visits, on household characteristics. We have data on the community health worker demographics. Who are they? Are they male or female? Are they primary school education, secondary school education? And we have information on how much supervision they get. And all of this data is just being collected. Some of it is being used, but a lot of it is underutilized. So I think a good point for us to start thinking about routinely collected data is to think about what data does exist within our programs. So what data collection tools are there, and what types of information are being collected as part of these tools. Now, I want you to think about problems. If you wanted to use that data for research, what could be some limitations of that data in research? So these are all really important limitations when you're thinking about using routinely collected data for research. One limitation that we didn't talk about is you can only use variables that are available. So maybe when Neza does her research on HIV, she wants to know how does income level affect the outcome. But if income level is not collected, then we could not include it in the research. And so one limitation is you are limited by what is routinely collected. One that most of you touched on is the data quality may be limited. And another point is extracting the data may also be difficult. So we are very fortunate that many of our programs have EMR, right? And so if I want to do a study about HIV treatment outcomes, I can go to Neza and I can say, Neza, these are the things that I want, and she can pull it from the EMR so I can do research. I do not think that is true for pediatrics. I think if we wanted to do a study on pediatrics, that data is there, but it is in the paper chart in the hospital. And so we have to do special data collection in order to extract the data for analysis. So as Jean Dedoux mentioned, several of these, particularly this middle one, is an example of measurement bias. So when we use routinely collected data, we are limited by what exists and the quality of that data. So that is a type of measurement bias. We don't have a lot of control to make the data better quality when we want to do research. But there are things that we can do that are solutions to these problems. One solution is, as we develop forms, we might want to have research in mind. So a good example is the oncology program that we have. They are revisiting their clinical forms, and they are finding some really key information that they need for research is not in the form. They're going back and they're looking at that form and thinking about, if we wanted to do oncology research, what is the necessary information we need to have? Now, it is a delicate balance, because NASA will come in and say, I need this for research. And PartA will say, there's no way I can collect all that information. I'm so busy in the clinic. And so you have to do what I call arm wrestling between what you want for the research and what is not too much of a burden on our clinical care. Another suggestion is that you have supervision that includes data quality assessments. And I know the Community Health Department is now starting to do this. When they go out and they say, how is your management of children? Is everything going okay? How is your management of pregnant women? Is everything going okay? They also look in the registers and they look in the forms to see, oh, you are missing some data here. In the future, can you make sure it is complete? Another suggestion is to make extraction a routine procedure. So again, we already do this in some programs. We don't really do it for research, we do it for clinical care. But a routine part of the HIV program is to make sure that data goes into the EMR. A routine part of our MESH program, our mentoring program, is to make sure that the supervision visits go into the M&E system. And so a routine part of these programs is the extraction of the data. And then finally, another thing that you can do is, if you want to answer a question and you have problems with getting all of the data, is to sample. So a lot of times when we want to answer a question about our HIV program, someone says, I'm going to look at 8,000 charts. That is very difficult to get data from 8,000 charts. Maybe we can randomly choose 500 charts and look at the sample instead of everyone. And that is one way to make it more feasible to look at our routinely collected data. There are some benefits. Data is free, and I purposely say free with quotations because there's still a cost to getting that data. Someone has to pay the data officers to enter the data from the MESH supervision forms into the electronic database. We are about to do a study on pharmacies in Bataro. Someone has to go to each of the health center pharmacies and pull the data from the stock cards. So it is free in the sense that it takes a lot less time and money to get data that is existing than to get data that you are doing primary data collection. You're starting from scratch. Often it does not require ethical review. And I emphasize the word often. So as you know, one of our roles in research is to make sure we are doing ethical research. We are not hurting anyone. We are not putting anyone at risk when we do the research. And different countries have different rules for what requires review and what does not require review. In Rwanda, if you are using routinely collected program data, you can get exemption from ethics review. They can say that data already exists. It is program data, so we are not concerned for the ethics around the data. So an example of that is information on how many children are we paying to go to secondary school, or information on how many food packages have we distributed in the community. That is program data, and it generally does not require an ethics review. In Rwanda, they do require an ethics review if you are using patient data, whether it is routinely collected or new data collection. In the U.S., that would likely not require an ethics review, or it could be an expedited, a faster review. But if you collect data on patients in Rwanda, you have to send it to the National Ethics Committee. So when I say often, if you're thinking about doing research using patient data in Rwanda, even if it is routinely collected, it will require it to go to the Ethics Committee. Generally, using routinely collected data is faster. It already exists. You don't need to design surveys and questionnaires. The data is sitting there. And then there is this benefit, this circular benefit between using routinely collected data and improving quality of work. So if I go into the pharmacy and I work with Pierre to collect data and do a project, and you see I am using your data, you will probably be more motivated to collect better quality data. And then the research in the future will be better. And then the program will be better. And we find this circular relationship when we do research using existing data. People in the programs are more motivated to do good quality care. So in terms of what study design can you use when you have routinely collected data, I just want to revisit some studies that we have discussed as part of this course. So this is one study that we discussed that was a cohort study. It was based on HIV treatment data, so this was the EMR data that Neza was describing before. It used EMR data to look at patient outcomes of the first 1,000 patients treated for HIV in our sites. This study was a case control study looking at treatment interruptions, but only used routinely collected data. Okay, so they used routinely collected data and combined it with a case control design to answer their question. And this is an example of a cross-sectional study where they were looking at data quality of sites in Malawi. And this is also a cross-sectional study based entirely on routinely collected data. So it's not like if you're going to use routinely collected data, you have to do a cohort. Or if you use routinely collected data, you have to use a cross-sectional study. There are many different designs that you can use, and you have to think about what data exists and what is the best design that you can use when you're thinking about how to approach your data collection. So routinely collected data works well with any of the 3 observational study designs: cohort studies, case control studies, cross-sectional studies. It does not work as well with qualitative studies or with randomized trials. So those studies, qualitative studies, remember we need perspectives, we need feelings. That generally is not captured in a form somewhere. Okay, so to get those perspectives and those feelings, we have to do primary data collection. And with randomized trials, I have seen routinely collected data used in randomized trials. One of the challenges is these issues around measurement bias and data quality. Generally, when we do a randomized trial, we want to have more control and higher quality, and so those things would not be acceptable, and we would put our own data collection processes in place. So typically, not always, typically when we think about studies, using routinely collected data, we're thinking about an observational study using one of the 3 observational designs that we talked about earlier.